to get started by welcoming back to the My Child Will Thrive Facebook Live, Dr. Peter Scire. And I'm going to tell everybody a little bit about him before we get started, just in case you haven't had a chance to hear from him before. Dr. Scire has dedicated his academic and clinical career over the past 15 years to working with complex neurological disorders in both adults and children. And he received his doctorate in chiropractic from Life University, as well as extensive postdoctoral training in functional neurology with concentrations in childhood developmental disorders, vestibular rehabilitation, and brain injury rehab. In addition to functional neurology training, Dr. Scire has amassed thousands of hours of continued education in the areas of functional immunology, functional endocrinology, and advanced concepts in neurochemistry and nutrition over the past decade. Since 2004, Dr. Scire has collaborated with Dr. Robert Melillo, the founder of Brain Balance Centers and Hemispheric Integration Therapy. After a decade of working with children, Dr. Scire established the Scire Integrative Health Center in Atlanta, which specializes in complex neurological metabolic disorders, utilizing the latest advancements in neurological rehabilitation and diagnostic testing. He's the founding member of the International Association of Functional Neurology and Rehabilitation. And Dr. Scire served as the president of IAFNR from 2015 to 2016 and went away from his practice. Dr. Scire is a dad to his now 18-year-old son, Nicholas. He had a birthday since we last spoke, and 13-year-old daughter, Emma. Thanks so much for taking the time to join us here again today, Dr. Scire.
Absolutely. It's always fun to have conversations with you.
Yeah, we get to talk about the things that you and I like the most. So
Absolutely.
it is a lot of fun. I feel very fortunate to be able to do this with you. We are going to talk all about today about primitive reflexes, retained primitive reflexes in particular. But why don't we start by for those people that aren't familiar with why this would be so important for them to pay attention for their child. Can you just start right from the beginning and let us know, let everybody know what primitive reflexes are and their importance in terms of the development of the brain?
Yeah, I mean, for starters, we definitely want to just kind of define what a primitive reflex is.
Yeah.
And so let's just talk about the aspect of a reflex. So a reflex in the human body is brought upon by some type of stimulation, usually a sensory stimulation, a sensory stimuli that then produces a specific motor response, okay? So for example, most people will probably relate to the fact that we have bicep reflexes and what we call deep tendon reflexes in our muscles. Well, the same thing neurologically that we actually had in early childhood. These primitive reflexes, we call them primitive because they actually start in the womb. Many of them start very early in gestation. Some of them appear later in gestation. And some of these primitive reflexes actually assist with the child actually being born and then lead to further development neurologically after the child is born. We refer to it from a standpoint of primitive in the sense to where, again, the fact that they come on early in terms of gestation, allowing for the fetus to actually move in the womb and respond to different stimuli in the womb, because again, the fetus is hearing sounds, it's getting input, and it's actively firing these reflexive reflexes, okay? Mm-hmm. So, and then depending on where they live, all the reflexes live in the brainstem. So again, we talk about how the brainstem is part of the primitive aspect of who we are in a human being. So that's kind of where the whole terminology came from, what a primitive reflex is. Now, the most important thing about it is the fact that these reflexes start in the womb. They, for example, we have like the asymmetrical tonic neck reflex, the reflex that initiates when a child moves their head and turns their head, there will be a certain motor response. When they rotate their head, there'll be an extension of the body on one side and a flexion of the body on the other side. And that's a reflex that comes on early on in childhood. So there is this sensory input that then causes this motor aspect. Now, when the child is born, in the terms of the maturation of the brain, most everything is at that moment reflexogenic. Mm-hmm. So all the movement, all the interaction with the sensory environment coming from the womb to now being in open air the child is now responding, or the brain is now responding on a reflexogenic aspect to sound, to light, to touch. And all these reflexes are actually there from a standpoint of survival.
So when you say that, so obviously these are things they need to have. And we always are hearing this reference to them, that they're retained. And when they're retained, they become not so positive in terms of the way the child is interacting with the world and the way their brain develops. Can you talk about the impact of retaining these past when you're supposed to have them?
Yeah, so there's a hierarchy of these reflexes that occur throughout the early childhood. So for most part, the generalization is, and there doesn't seem to be consensus on this, but the generalization is that most of these reflexes should be inhibited by probably no later than 12 to maybe extending out to 15 months of life, okay, under normal trajectory of brain development. And we have these different reflexes that, again, are present in early gestation, that some of them are gone by 3-4 months. Some of them are gone by 6 months. Some are gone by 6-9 months, and then that 9 to, say, 12 or 15-month aspect. So really what we begin to look at is that when we start examining pediatric cases, is that do we start seeing these reflexes exist between after 15 months. And prior to even actually examining the infant at that moment to look at these reflexes, we're probably going to be able to start seeing signs of some type of motor delay, okay, in the sense to where are we not seeing muscle tone, and especially really about muscle relationships, proper coordination of the head and the eyes in terms of movement, okay? These are things that are early signs to, or a child not responding to a stimulus, okay, one of the really most common reflexes that we see a lot of times in childhood is the idea that the mother would like to breastfeed, and yet the child is not actually attaching. And that's probably because of the fact that the rooting reflex is not present, because early on, and it's one of the early reflexes that should be present. So that way, the moment that the child actually comes up against the breast, that it begins to latch on to the breast to be able to feed. So again, these are early signs that, hey, these reflexes are there. Now, what we're thinking and what we're seeing in the literature, and again, the literature is pretty sparse on this. I mean, it's in the sense to where there may be about a 50 to 75 really good research journal articles on this. A lot of this work early began when I looked and reviewed research on this, that some of the primitive reflexes may have been early identified, 100 years ago, 125 years ago by early, scientists, but it really wasn't until maybe about the early 70s when people really began to start looking at, is there a relationship of potential reflexes that are early signs of childhood development? Because for most instances, if you talk to most pediatricians or you talk to most traditional educated medical physicians, most of them only look at primitive reflexes in relationship to injury, okay? To where if, maybe it's the child with cerebral palsy, okay, or a child that had a stroke or some type of traumatic injury to the brain, as opposed to looking at it from a developmental standpoint, a relationship of these reflexes, if they're there and present beyond 15 months, it's a real sign that there's immaturity and maturation of the brain.
Yeah. So, well, and actually, one of the things you said in terms of about the rooting reflex, I wanted to go back to that for a second and just ask you about that. If parents are seeing that they actually don't have the primitive reflexes, some of the reflexes aren't really there and aren't developed upon birth, is that something is that part of the earlier development that we should even be highlighting and making sure that we're being extra careful as they move forward to see that not only do they acquire those reflexes and then also inhibit them when they're supposed to?
Sure, absolutely. Because anytime I see a friend who has a newborn or has somebody between the ages of 0, a day old child to 12 months old, I'm literally grabbing them to make sure and seeing whether or not I actually see these reflexes, okay? Because if they're absent, in 0 to 3 months, say for example, that rooting reflex or the graft reflex. Again, if those are absent, a graft reflex is a reflex where that upon putting an infant feeling something against their hand, they will grasp it.
Yeah.
Okay. All right. So again, if that reflex is not present, or the rooting reflex, when you stroke the outer portions of the mouth, if that reflex is not there again, or the mom's telling you, hey, I've been trying to breastfeed, but yet my child won't attach. Like my own daughter for a while there, she didn't want to attach, and we did a lot of stimulation. Now, again, back to the simplicity of it is that it's a reflex. Okay. And so a neurological reflex has two major components: the sensory compartment of the reflex, or the sensory input to the reflex, and then the motor output. So, for example, in that sense to where all of a sudden the child is supposed to attach to the breast, but yet that sensory aspect, you got to start thinking, is there some level of muscle tone issues because we're not putting the pressure of the tone on the muscles should go and grab and have that rooting reflex happening? Or same thing here, is that I feel something here, and then but I don't initiate. So again, that's part of it, is that is there all of a sudden a sign of some tonality issues in the muscles and the receptors, the muscle spindle receptors, that are not feeding into that reflex and now producing an appropriate motor response.
Yeah.
And so that's a big thing, is being able to sit there and go through the different stages of where, okay, by 6 months, they should have had these certain reflexes that are present. Certain ones should have been diminished, because if we don't catch these early enough, well, if we catch them early enough, there's an opportunity, obviously, to turn them on if they're turned off, or if they're lagging behind, to try to inhibit them. Because if we don't, there's a lot of literature now saying that, again, by 12, 14, 15 months, if these reflexes are retained or persistent, as the literature refers it to, we can begin to start looking at the trajectory of the child neurologically and saying, is this child now going to develop some type of neurodevelopmental disorder?
Okay, so let's actually dig into that and talk about that part of it. Can you explain to everyone how that development, like in terms of what are we looking at so we have the early primitive reflex and then we have the inhibition of them. Why is it that when those reflexes aren't inhibited, the brain develops differently? So where are we talking about within the brain that this cascade of events happens?
Sure. Well, the relationship of it is because of where these reflexes live in the brain. Okay, they actually all live in the brainstem, and the brainstem has 3 different levels. And so I have a nice little drawing here for everybody. It's pretty simplistic, but let's start with the lower part of the brainstem. Okay, so we have the medulla. The medulla oblongata is the lower part of the brainstem. Okay, so right underneath this would be our spinal cord. Okay, then we have this area called our pons, and then we have this area called our midbrain. Now, again, this is the 3 layers of the human brainstem. Okay, so we have certain primitive reflexes that pretty much live down here in this pons and medulla area. For example, reflexes like the asymmetrical tonic neck reflex, the symmetrical tonic neck reflex, the tonic labyrinth reflex. These are reflexes that live in this portion of the brainstem. And again, I don't have it drawn in here, but there's a whole lot of anatomy that's in here. And one of the big parts of the pons and medulla is the relationship to our vestibular system. And so when we're looking at those 3 reflexes, we're getting a great window into looking at the way those reflexes are allowing for proprioception, vestibular input, and oculomotor input to actually work together. And so these reflexes, what they're designed to do is they're involuntary. Okay, they produce a stereotypic motor response. Okay, in all human beings. Okay, regardless of sex, regardless of race, is a very stereotypical relationship. Okay, they're not under cortical control, meaning that again they're sitting in that primitive part of the brain, the brainstem. They're reflexive. Okay, so when we have the presence of, let's say, the asymmetrical reflex or the symmetrical tonic neck reflex. These are reflexes that again are going to probably produce disturbances in vestibular function, oculomotor function, so our eye movements, and proprioceptive base aspects. So typically, if we start seeing children that are now showing signs of motor incoordination, hypotonia, low muscle tone, okay, muscle imbalances maybe from one side of the body to the next. Again, having good scanning movements of their eyes, okay, or rapid movements of their eyes. And we call it saccades. These are all signs that hey, we need to go back and we need to check the early start of those pathways, because over time, as the human brain develops in the early first 12, 13, 14 months of life, what happens over time is the upper parts of the brain, the cortical networks, more specifically the frontal lobe, comes down and inhibits these reflexes. And they inhibiting in the sense to where now they become the back end of the nervous system. They're in the background, and so they're allowing for us to now develop more complex motor coordination, because our motor system will integrate these reflexes at any given moment to allow us to do something with a greater degree of specialty in motor aspects.
So actually, a question just came in from Allison, and she's asking which reflexes that pediatricians are most likely to miss. So do you know what a typical reflex, because some pediatricians will check some reflexes. I'm not sure how many check all the primitive reflexes. What would you say from your clinical experience you've seen that that's getting missed most of the time?
Well, I think in a standard pediatric neurological exam, and again, that should be the rooting reflex, the Graf's reflex, the Babinski. Okay, and again, most people will check the Babinski because they're looking to make sure that that's one of the one reflexes that's very related to brain injury or stroke or cerebral palsy. That reflex is there. That you stroke the bottom of the foot, and all of a sudden we get this outgoing toe and fanning of our toes and stuff like that. So that's one that needs to be checked to make sure that we're looking at that. Then comes the next several reflexes: the asymmetrical tonic neck reflex, the symmetrical tonic neck reflex, the tonic labyrinth reflex. Again, a tonic labyrinth reflex in an early infant, what'll happen is that as you move their head into extension, do they go into extension? As you bring their head into flexion, do they go into flexion? Okay. Now that's in an infant. Now in a child that's, let's say 2 or 3, or even an adult, because again, what I definitely want to touch in is that adults that are struggling or have a variety of different neurological things going on, the first thing that I check on them is all these primitive reflexes. But let's say we're upwards of 3 years old or into adulthood, how we would check the symmetrical tonic neck reflexes, having someone stand together with their feet together, eyes closed, put their head in extension, and start looking and see if we see any sway patterns, and put them in flexion, see if we see any sway patterns. Okay. Again, in relationship to the asymmetrical tonic neck reflex, the symmetrical, we want to also look at the Neuro reflex. The Neuro reflexes are a startle reflex. So again, this is one of the earlier reflexes that come on in gestation and then right there at birth again. And there's 3 major components of the Neuro reflex. We want to look at it from a standpoint: do we get a startle response with light? Do we get a startle response with auditory input? And do we get a startle response with some type of change in our head position because of the vestibular relationship? And the Neuro reflex lives up more in the upper part of the brainstem, the midbrain. So always M for M. Okay, so we'll keep it simple. But those reflexes, they're there. And then I would also look at the Landau reflex, and that's a reflex that again we can see. And those are the ones. There's several others, but for the most part, those are the most reliable ones to look at.
Yeah. So actually, can you list those off again? Because we were talking about that before we got started here today live, that there are a lot of primitive reflexes that are listed out there, but there are ones that you feel, based on the literature, are most reliable in terms of assessing a child and then also rehabbing. So can you just list those ones off for us?
Yeah. So the rooting reflex, the Palmer-Grass reflex, okay, The asymmetrical tonic neck reflex, we refer to it as ATNR reflex. The symmetrical tonic neck reflex, STNR. The tonic labyrinth reflex, the Neuro reflex, okay? And then the Landau reflex. And then for others, you can throw in the Babinski reflex, because again, we're looking at that one to make sure to rule out that we don't have an upper motor neuron lesion, okay? So we're looking at to make sure that there's not a damage from the motor cortex down to the opposing side of the body in terms of voluntary movement and stuff like that. And then the other aspect of it is that we get into the relationship of what is considered a primitive reflexes versus a postural reflex.
Mm-hmm.
Okay, so then we have these postural reflexes that supersede, that come after the primitive reflexes. So again, if we don't have these primitive reflexes go through their natural inhibition cycle, then we're not going to get the relationship of the postural reflexes. And the postural reflexes then what allows the infant to go to a more higher degree of specialization and motor development.
Yeah. So Allison, back to Allison's question, I'm not sure she was referring to reflexes that should be checked as an infant, or if they were ones that should be addressed as they come, sort of when they should have inhibited them. Are you finding that pediatricians are checking them around their second birthday to see if they still have retained primitive reflexes from your experience? Or should this be something we want to be seeking out as a parent to make sure we're going to a practitioner that's, whether it's a pediatric OT that specializes in them, a functional neurologist or something else?
Yeah, my experience is that we're not seeing that in terms of the traditional pediatrician model. I think maybe because so much more attention has happened. I remember when I first started doing this work in the early 2000s. I mean, no one really knew what primitive reflexes. Anytime I would lecture, and even when I got a lot of different reports from different providers, again, even in the occupational therapy arena, there's still a certain amount of OTs that may not assess these. As now, flash forward 15 years, because of the age of the internet, there's a lot more of that, or the age of social media and stuff like that, and what you're doing, bringing more awareness to this. So there's a higher degree of awareness to this. Doesn't necessarily mean it's translating into a clinical model, whether it is the pediatrician assessing this or the various aspects. I think anybody who's been taking classes through IAFNR and through Dr. Malillo, I sure hope that they're all assessing primitive reflexes on every patient that walks in the door, regardless of what their neurological symptom might be. But again, I think that is two aspects. Is number one, that if we're talking about infants and through the first 0 to 15, 16 months of life, that they are going through the natural progression of the reflex integration, okay? If they are not, then looking at potential motor milestones that may be now being begun to be missed. And again, and probably some of the biggest ones is obviously how the ATNR, the symmetrical tonic neck reflex, and the TLR are reflexes that begin to allow for the integration of the brain, of different parts of the brain, to drive crawling and then eventually drive walking. Okay. And if we now have a situation where we have a child that had a delayed crawl or an abnormal patterning of a cross crawl, okay, then we know that reflex that we definitely want to, that I skipped over, that we definitely want to add in, is the spinal glenoid reflex. That's the reflex that we want to make sure that we have there. And so again, those early signs. So we're looking at the relationship of, is a child developing more independent eye movements, around 4 to 6 months of life, greatest aspect of muscle tone, so that way they come up and they're sitting upright. Are they rolling over appropriately? Because we get into some of those postural reflexes and stuff. So
yeah. And I think one of the things that's important for parents that are listening that have their children are past that early infant stage, going back and reflecting on, medical history is so important. Reflecting on what their kids were doing at that stage is incredibly helpful to be taking to your practitioner as they go through and get assessed now, because it'll give indications of how long these things have persisted in what way and where they might have started from. Would you agree with that?
Yeah, without a doubt. And again, the literature is clear on the fact that the more there are, the more neurological immaturity that we're going to see in later networks of the brain. Okay,
Yeah.
and networks, and that's where some of the research is now going, is really being able to quantify and say, okay, hey, the one clear aspect of all of these neurodevelopmental disorders is that we see changes in posture, in muscle tone, we see underdevelopment in the vestibular system, or we see inappropriate oculomotor function. Again, I call it the triangle of those three systems having to work synergistically. Those are a lot of signs that we see in childhood, but we also see them in adults. I mean, and that's where most of my work is now really in working with adults. And when a patient presents, even with a case of anxiety, I've had recently a 27-year-old patient come in and had full-blown anxiety. And as soon as I checked the Neuro reflex, she had an active Neuro reflex. So the active Neuro reflex is a sign of a fight or flight reaction. So here she is, that she's been bombarded with a light or sound or any type of movement. Does she engage her fight or flight response? And people had been trying to do other things to her to treat her anxiety, but once we started actually integrating that Neuro reflex, our anxiety started going away.
Yeah, which is amazing, and it actually goes to the why we said when we put a title around our conversation today, which was how retained primitive reflexes can impact us at any age. Have you also seen, to that end, to continue that train of thought, have you seen where patients, especially as adults, but it could be even in children as well, have had some kind of injury? Could it be a concussion or something that would actually have put them, their retained reflexes represent?
Yeah, because ultimately, when you look at these reflexes neurologically, they come under the control of the frontal cortex. So now all of a sudden, let's say someone suffers a concussion, and again we have this immune response in the brain to where we have this neuroinflammatory response that changes one of the things, again, people have to look at now is really a relationship of the cells of our brain, that we have all these neurons, but we have all these glial cells that are there, and they fire up and become active, these microglia, that now all of a sudden that become inflamed and now change the electrical activity of that frontal lobe. And so now all of a sudden we can actually have what we refer to as frontal release signs. Okay, now we lose the inhibition down to the brainstem, and now we have these active reflexes. And we see it also in other more advanced neurological disorders like Parkinson's and Alzheimer's and movement disorders and stuff like that. So again, going back to, and the question is, in the case of that, the child or the young adult that suffers a concussion, one, were their reflexes truly integrated? Okay. Or why are they or did the reflexes reappear now because of a frontal lobe injury?
Yeah. Well, and I guess that, which also a lot of these kids have neuroinflammation from other, not just from trauma, but from other injury points or viruses or bacterial problems that are causing neuroinflammation. So really, we could be looking at this from lots of different angles in terms of why these things are showing back up again, or that it's just being exaggerated because they've got this activity in the brain as well.
Yeah, and again, and so the take home is definitely making sure that we're going through and checking off these reflexes, because if these reflexes do not become inhibited, then they're going to, now there's thought that this can lead to why we may see underdevelopment or changes in the volume or the maturation, the anatomical relationships of key structures like the cerebellum. Cerebellum is attached to the brainstem. It's mostly coming through connections between the cerebellum, the pons, the middle part of the brainstem. And so again, if these reflexes are not going through their normal maturation and integration, then are we firing into areas of the cerebellum that are going to lead to a specialization of those pathways in the cerebellum?
Yeah.
And that's going to have a whole downstream relationship to what's going on in future pathways that are going from the cerebellum to the frontal lobe and so on.
Yeah. Well, and I'm hoping we're going to talk on another day all about the cerebellum, because we love to talk about that as well. We have a lot of questions coming in, so I just want to get to the questions that are coming in here. I also, let's see, we had a couple that came in before the live started, but I'm going to start with the live questions first. Greg's asking, what advice do you have for families who have been searching for treatment options for multiple neurological issues for many years, tics, anxiety, OCD, SBD, etc., and are just now coming to primitive retained reflexes and searching for treatment options to see how that is playing a role in the big picture for an 11-year-old?
Mm-hmm. All right. Well, obviously, I want to show my bias here in a sec, but I would get to obviously a trained functional neurologist or to a brain balance center. And because again, these are people that have a tremendous amount of aspect into looking at these primitive reflexes. And then from there, being able to assess it. You know, the other aspect of these reflexes is relating it to a hemispheric relationship. There are aspects to where do we see a greater degree of a retained reflex on one side of the, for example, with the palmar reflex, is it more apparent on the right-hand side, right palm versus the left palm? Again, looking at that and saying, okay, that's a relationship to a right hemispheric immaturity or left hemispheric immaturity. So that's a big key factor is being able to start out with these primitive reflexes and then get further into the other aspect of a full-fledged neurological exam. Okay, there is, in those three major areas of the brainstem that we talked about, the midbrain, the pons, and the medulla, there's 11 of our cranial nerves that sit there. Okay, so again, making sure that we're going and having a proper cranial nerve exam done, because if we suspect immaturity in different parts of that brainstem, we probably should see other parts of that brainstem not functioning as well. So again, it's going through and really looking at all these different electrical these neural pathways in the brain and saying, okay, hey, here's what we're looking at. We're looking at, underdevelopment in the vestibular system, or we're looking at underdevelopment in structures in the cerebellum that relate to muscle tone and posture and balance and gait, and motor coordination, motor planning. Do we have problems in the upper parts of the brain? Are we looking at problems in the visual centers of the brain, the auditory centers of the brain? That's where I would start, is getting a functional neurological examination, because at the end of the day, we're looking at the function of the nervous system. I think this is a challenging thing for our parents, is because, again, most parents and even in whether we're dealing with adult children disorders or adult disorders, I think the frustration for the patient or the caregiver in this instance is that everybody puts a label on something and just says, okay, your child has XYZ, or you have XYZ in terms of depression, anxiety. And depression, anxiety doesn't look like, it's an N value of 1. Autism is an N value of 1. ADHD is an N value of 1. It's how it's expressing in your child, okay? And in terms of, there is a general relationship of things that can be happening, but it's an individual relationship, because we have to account for genetics, we have to account for epigenetics. Again, not every child that I've seen is going to have, every single one of these primitive reflexes retained. They may have only one out of the major 7 or 8 that were they have, where some of them may have 7 or 9, or even adults that I assess and stuff like that. So again, remembering that we are taking a functional relationship and going forward there.
Yeah. I think it is a real struggle to find a good practitioner. I recommend people go to the iAfter or website. I believe it's iAfter.org. We'll try and link that through in the comments after the live today. But they have a practitioner. You can search for a practitioner on their website. But it is difficult. You got to ask all those questions around, is this who do they normally work with, and how do they like to work with them? And same way you would interview any other practitioner that you'd be working with your child. But it is a challenge, I know, to find the right person to work with. If you don't have someone, often a lot of the practitioners like Dr. Scire work remotely with patients as well. So make sure that you reach out to him as well to see if it's a good fit as well. I know he's not going to say that here, but I'll say it for him. Allison's, not Allison, Autumn asks, are these primitive reflexes tied to kiddos expressing sensory processing disorder? And this is a good one. You can take that away.
Yeah, I mean, again, you can basically fill in the blank with any type of diagnosis. Okay. Again, for me, sensory processing disorder is really the relationship of how is the nervous system being able to respond to the sensory relationships that are coming in, the sensory input coming in, and then the appropriate motor response. I look at it from a standpoint of when we have these primitive reflexes that are there and have been present for a long time, they are a sign of brain delay or brain immaturity that's now holding up the brain from actually developing its asymmetrical distribution of function. Okay, what makes the human brain so unique is that we're lateralized. So our brain is the most lateralized brain in all the animal kingdom, and so in order to get there, we have to go through these steps, and these steps start with these primitive reflexes leading to postural reflexes, which ultimately lead to more complex motor function. And what I mean by complex motor function is something that's goal directed. Okay, meaning that the young child wants to grab that pen over here, or grab that block and take that block and put it over here. And it's a goal directed relationship. So when we have simple motor function, we're going to have simple pathways in our brain. When we have more complex motor functions, we're going to have a greater degree of complexity in our brain. And what happens with the human brain is, as we begin to grow, we get this asymmetrical development of our human brain. And usually it starts when 0 to 3 years is more of our right hemisphere developing neurologically than our left hemisphere. And every several years, there's a switching of effect until we fully get that full adolescence or young adulthood, where we get this full relationship of functionality. And so what's really happening is, or what's not happening in any one of these disorders that we want to fill in the blank, is that we're not seeing that specialization occur, that we're not seeing that differentiation, that we're not seeing these neural networks being formed on the left hemisphere or the right hemisphere, and then really looking at the intra-hemispheric communication and how that everything we do in the human brain is really related on the synchronizational aspect of these neural networks in both hemispheres firing simultaneously at a given moment to allow for that particular functionality to occur.
Yeah. So, and actually we've got another question that is related to that, but not exactly the same. Valerie asks, my 3-year-old seems to like he's on the fast track to ADHD. His OT thinks that many of the symptoms may dissipate if as we address his 3 retained primitive reflexes. Have you noticed the same? I'm trying to latch on to hope.
Well, absolutely. Number one, I do believe that you can inhibit these reflexes. We've been able to inhibit them through a variety of different exercises that are there, and then as well as other stimulation to neuro access to the different parts of the networks that we want to stimulate. So yes, and as you begin to see these reflexes, will you begin to see functional changes in the child? Absolutely. And it's probably a little bit more complex in the context of, what other changes. It's hard to say unless, obviously examining a child and say, okay, hey, how fast is this going to resolve, and what are other aspects? Okay, when you get into potential naming of a disorder, I don't try to label a child right away. I want to make sure that we're just going through these normal neurological steps. And because of, again, we talked about a lot, a couple weeks ago about neuroplasticity. Okay, the idea is that we stimulate a pathway. It's the more it's stimulated, the more it's going to create a gene response. The gene response is going to now create the connections and increase the connectivity, because at the end of the day, we're talking about the density of these connections, the strength of these connections, in the different regions of the brain. She's ahead of the curve right now by getting in there and doing it right away, because again, the plasticity effect is so great in a young child that she should be able to get to her desired level by addressing the primitive reflexes, but remembering there's a whole host of other relationships there to make sure that we're looking at and stuff like that. So
yeah, and I think actually to that end, maybe you want to just touch on again the importance that we're talking today and focusing on primitive reflexes, but they aren't the only thing that we look at. So, and you have talked about that sort of in the comprehensive neurofunctional neural assessment. So as we talk about this today, I think it is important for everybody to remember that this is a piece of the puzzle. It's not the entire picture, and that they want to make sure they're getting to someone that can do that full neuro exam for them.
Yeah, and that's the most important thing, is getting to someone who has the capabilities of doing a full-fledged neurological exam. The primitive reflex exam, usually I do an exam, it takes about an hour and 15 minutes. The primitive reflex exam for me is 7 minutes of maybe that hour exam. Okay, it's one facet of the exam. We then talked about cranial nerve exam, okay, having a full-fledged cranial nerve exam done on your child or adult. Then looking at the vestibular system. So looking at now vestibular testing, okay, and depending on the age of the patient, there's a whole host of things. Obviously, in the adult population I work with, I have advanced vestibular technology that I'm assessing and posturography that I'm assessing. But in a child, there is different simple bedside tests that we can do to look at their vestibular system. Then looking at their muscle tone by just simply looking at what we call muscle stretch reflexes. Okay, these are your reflexes like your bicep reflexes and your tricep and your patellar reflexes, to look at, does the nervous system respond correctly to that stimulus? Do I get that appropriate reflex, or do I get one that's hyperactive, or do I get one that's hypo, it's not responding? There's ways to look at just muscle tone and measure the relationship. Then we get into looking at balance and posture and gait mechanisms. We can look at sensory aspect by just taking a pinwheel and running it down different parts of the body to look at the sensory aspect. Or can a child or an adult differentiate between certain different forms of tactile stimulation? So I don't want everybody to get so hung up on that I remediate primitive reflexes and I got everything figured out. That's not the case. Primitive reflex is just one facet of a total neuro exam. That if you're going to some practitioner that is keeping up with the times and doing a good job neurologically, it should be probably one of the first things they do, and then lead into a greater battery of exam testing and stuff like that. And then you can get further into more advanced testing if you want to start getting into neurocognitive testing and stuff like that. So
yeah, and that's why it's the reason why we talk about primitive reflexes so much is because is what you talked about earlier, is that it's sort of the beginning of where we see the brain starting to develop offline, and it's an early indicator maybe that there's something we need to be working on, but it isn't everything. So I just wanted to make sure that you touched on that for sure. I have another question here. Tracy is asking, is there a relationship between retained primitive reflexes and dysautonomia?
Again, and when you look at that in relationship to the function of the vagus, absolutely. Okay, and you're really looking at the end of the day, what we're talking about here is that if the infant, early child does not go through these normal, I appear, I turn off, I appear, I turn off mechanism of these integration of the reflexes, it won't allow for the next state of neural networks to be developed appropriately. So a great deal of our neural pathways are inhibitory to each other. So we may not get, for example, if we have a Neuro reflex that's too active, we may be overdriving our sympathetic nervous system, and we may not be getting the dampening effect of the sympathetic nervous system. And when the sympathetic nervous system is overfiring, overactive, it's going to dampen the parasympathetic nervous system. Okay. For example, if we have signs of where we have the retained asymmetrical tonic neck reflex, the tonic neck reflex, the symmetrical tonic neck reflex, again, these sit in that medulla pons area, very close to the vagal nerve centers. Okay. Mm-hmm. So again, looking at that and saying, if those reflexes are not integrated, am I going to get the appropriate response from my vagal centers? Am I not getting the appropriate input from my vestibular portion into my brainstem, the cerebellum into my brainstem? So again, it's the relationship of that. If these reflexes have gone awry, then the end of the day, there's a good chance that we're not going to see the next engagement of the more complexity of our nervous system that could lead to different aspects. But I'm definitely not going to go and look at dysautonomia and say that I treat premental reflexes, everybody's dysautonomia is going to go away. It's a little bit more complicated than that. Yeah. But it could be a facet.
Yeah, and actually, it's a good thing in terms of refreshing the memory in terms of the impact of that on the reflexes on the sympathetic parasympathetic balance in these kids, because they are. I mean, if you have for example, even if you have a retained Neuro reflex, your startle reflex is there, you're going to be, like you were talking about with patients with anxiety, they're going to be in sympathetic dominance most of the time. So, and our kids tend to be there.
Exactly. And think in the terms of just from a metabolic aspect now. So now all of a sudden I'm in a sympathetic dominancy. What am I going to do? Let me just be constantly barraging my body with catecholamines. Okay. So now I'm going to be constantly driving that system. Am I going to be driving cortisol up? So now all of a sudden I drive cortisol up. Here's the big thing: as cortisol goes up, it starts now breaking down the intestinal gut lining. Okay. So now all of a sudden I have this cortisol cycle. And that's a big thing. Is, so let's say, for instance, that you may be doing an elimination diet. You may have eliminated all these nasty proteins that we want out of our child's diet. But if I never went in there and actually dealt with the autonomic aspect of it, I still may have intestinal permeability, not because I haven't dealt with the dietary aspects or not trying to heal the gut through a variety of different nutraceuticals that we know that are there. But the relationship that I have sympathetic dominance, I'm driving up IL-6, okay? I am driving up cortisol levels, okay? So I'm going to destroy the intestinal permeability. I'm going to drive down secretory IgA. So I think that, again, back to our conversations over the years, has always been, we can't get tunnel vision. We can't just look at something from purely a metabolic standpoint or purely a neurological standpoint. And I think that that's one of the things I lucked out in my career, and the timing of who influenced my career was I got to learn from several of the best in the neurology world and some of the best of the metabolic world. And that's why I do integrative functional neurology, because I count for both of those scenarios. I cannot just examine a patient and not have all that in play.
Yeah, no, it's very, very true. So I have a couple more questions here. Anna says her 8-year-old child that consistently has a very loud voice, she says, and finds it very difficult to speak quieter. Is it possible this is a symptom of a primitive reflex not resolving? Her hearing has been checked out and it's fine.
Yeah, when you look at, again, when you start looking at comprehensive autometric testing and nothing seems to be awry there, then I would immediately go back to now looking at those primitive reflexes and just starting through every one of them and check for everyone. And for the parents, the reflexes, they're very easy to check. And I just happened to be Googling last couple of days, and there's so many resources now online for people to just find some basic videos that might be out there regarding how to check reflexes and stuff, or Robert Malolo's books that are out there, or Sally Goddard's books that are out there that are great references for just how to perform a basic pediatric primitive reflex assessment, to then go, okay, which ones are retained, and then how there are some basic exercises to do. And if you're doing the basic exercises and we're not seeing improvement, then that's again why you want to consult a functional neurologist or someone at a brain balance center, because there's a little bit more complexity there involved in what might be the reason for why those reflexes are not inhibiting based on you doing the standard protocols that are out there.
Yeah. So we also have a question from Daniela. Daniela's asking, does it make sense to work on the retained reflexes if you have a child with, I think we've already answered this one, if you have a child with food sensitivities and probably an inflammation and the family is not willing to change diet? So
again, I mean, at the end of the day, you want these reflexes gone. And so you have to get these reflexes, because it's the brain is almost just sitting there suspended neurologically, and it's going to allow for some level of further development and further specialization. Again, the biggest concept that we have to drive home here is that these are staging functions of the human brain that allow us to then develop this specialization, this lateralization, and ultimately this synchronization that happens. Okay, and the brain is developing from bottom up, top down relationship, and it's also developing from a posterior relationship going forward. This is why the human frontal lobe is the last thing to fully mature in a young adult. And so again, we have this relationship of, we have a vertical development, we have a horizontal development, and ultimately we have this synchronizational relationships. And if we retain these reflexes, because again, now for the last 4 to 5 years working with adults, adults come in and they have a wide variety of neuropsych stuff going on. They have autoimmunity going on. They have potential mild cognitive impairment, patients that have had TBIs, traumatic brain injuries, or concussions, or already been diagnosed with neurodegenerative disorders. As I do my comprehensive case history and get a lot of information, I still have information on my forms for adults that have to do with their childhood development or their teenage development in their 20s. And it's one of the first things I do, regardless of what type of symptom I might be dealing, is that primitive reflex exam on the adult. And I'm here to tell you, I've found primitive reflexes retained in a large majority of the adults. And so the question is that in the TBI case, is it there because of the traumatic brain injury? It may or may not be there. It could have been there prior to that. But again, if an adult is telling you, hey, I struggled with ADHD in my adult, in my early childhood, and again, I'm 43 now, so I get the opportunity to meet a lot of adults that are my age that grew up around the same time, and they're like, oh yeah, I had a learning disability, or I had a ADHD and stuff like that. And so the first question in my mind is that they probably had retained primitive reflexes. And now these developmental disorders that they had in the childhood are actually the staging sites for future neurological aspects, but then wrapping around it now, potentially the autoimmunity that's been there, because again, for another topic of day is how there's lateralizational functions on the immune system and the GI system and the cardiovascular system from one hemisphere to the next to the other.
That's why we could talk forever. And actually, you just, I think, answered one of the questions that came in from Anna. She just asked, does this therapy work on 40-year-old adults too? And I think the answer is yes.
Yeah, absolutely. And I think the great thing about actually working with adults is that when you have an adult, working with a ped, working with a young child, again, you're going to run into some of the compliance aspects of getting them to do the exercises. But the one thing about working with adult is that because they actually have frontal lobe integrity, they themselves could really help voluntarily control the inhibition to that particular reflex by having them do that. If we're doing a Neuro reflex and the startle reflex and we're trying to inhibit it, again, they're conscious thinking of, hey, I'm firing my frontal lobe by concentrating more than like a 2-year-old's going to try to concentrate in terms of doing a reflex activity. But the 40-year-old person is going to concentrate, and that concentration is going to fire their frontal lobe. And at the end of the day, the story is frontal lobe comes down, inhibits that brainstem, modulates it, and boom, within a very short period of time, we might be able to inhibit that reflex.
Yeah.
So.
Well, so Andrea then asked, my ASD 18-year-old has always been slow moving, slow to answer. What should I look at?
Start right there. I would definitely start with all the reflexes, getting them all checked. And again, from A to Z, from that rooting to the Neuro, to the Palmer, then the asymmetrical, the tonic neck reflex, the symmetrical, the spinal galant, the Moreau, the Landau. Those are all the big ones. We can get into further ones, but those are the big ones that, at least within a matter of 5-6 minutes, we can check all those and know where we're standing. Mm-hmm. And then again, with any patient, further go into a more sophisticated functional neurological exam to look at other aspects, because now we're starting to look at downstream problems. We're starting to look at at the end of the day, how did the brain begin to specialize? Did we get all this greater degree of differentiation and specialization within the hemispheres, within the different parts of the cerebellum? And if not, then how can we begin to remediate these things? And because again, I kind of alluded to a case that I've been working with now for about 9 months, and it was a 17-year-old, now 18-year-old child on the spectrum. And again, his family had reached out to a lot of people, and no one had really ever done a full comprehensive exam on the primitive reflexes. And so once we started doing that, and started integrating those reflexes and combining that with a ton of vestibular-based therapy and cerebellum-based therapy and oculomotor-based therapy, other things started to develop. And now as his motor system develops more complexity, now we're seeing more complexity in ultimately cognition. Mm-hmm. And I think that's what parents ultimately want is my child going to someday speak? Is my child going to have a sophisticated language? Is my child going to be able to hold a job down? All these things. And so at the end of the day, as the motor system becomes more complex, more specialized, that's what's driving the advancement in cognition. And so we have to assess, and remediate.
Yeah. And I think that's what you were talking about there, is that, that's the one thing that's really exciting about doing this type of work. And we'll talk about that when we get into the whole cerebellum and where it goes from there. When you talk about slow moving in the processing, as those primitive reflexes get integrated and we start to get higher function, coordination of everything. So in terms of the ability to process the information tends to speed up. Obviously you're going to look at the metabolic side of that as well, but that's what's so amazing about it. It seems, from a parent's perspective, when you start to see what type of work you're talking about doing in terms of rehabilitation and what the exercises look like, I think a lot of people are surprised of the impact that they can have, because they seem so innocuous, I think, to the untrained person. So what I can tell you is from personal experience and from the parents that I know that have done this type of work, it opens a huge chain of positive events that just unravels a lot of potential there.
Absolutely. And again, one of the areas that I'm really passionate about now over the years is obviously working with so many of women that, and a lot of the women that actually see me in Atlanta are probably mothers of children with special needs. And again, they're constantly in that fight or flight response. They're constantly, and this is why you're seeing an explosion in these autoimmune disorders, because they're driving those inflammatory pathways. And again, inflammatory pathways can be driven through foods, they can be driven through infections. But I think one of the biggest things that we're seeing more than ever is the psychological stress, the mental stress that is driving that. And I relate that back to a lot of women when they are in these stress responses. They're not managing their blood sugar, so their blood sugar now are getting all types of basically insulin surges, and now we're causing all kinds of inflammatory cascades. But for me, one of the first things I'm going to do with these women is check these primitive reflexes, and a lot of them I've caught a Moreau, or I've caught other reflexes, and then once we get in there and we start stimulating these reflexes, it calms it calms them down. It allows them to integrate. It allows them to make better, choices, because a lot of times with the frontal lobe is that if the frontal lobe is not firing, we're not going to make good choices as an adult. We're not going to be able to inhibit our limbic system and stuff like that. So
yeah. So we have a few more questions. If you have a couple more minutes
yeah,
to
sure.
stay here with us, because I've got some that came in ahead of time as well, but I'm just going to clear off some of the ones that have come in while we've been live as well. So Julie asked, how can I find a functional neurologist? Julie, we're going to link to a couple websites after the live is over with, where you can get to practitioner
Yeah, I mean,
directories.
there's great resources. The two big
Yeah.
resources are International Association for Functional Neurology and Rehabilitation, IAFNR, and the Carrick Institute. And
Yeah.
you're not going to go wrong with anyone who's been trained by those two institutions. So.
Yeah. Yeah. So we'll make sure we link to those websites so you can look on there. They have good directories on there that you can find people. Carol asked that you'd mentioned epigenetics. Can you just explain what epigenetics are for those people that don't understand?
Sure. So again, in a very simplistic level, and I don't want to, because we can go down the snake hole with this, but at the end of the day, epigenetics is the expression of our gene. Okay, that we have a gene and we have this DNA sequence, and epigenetics is how does that gene actually express itself. And the expression of the gene is really dependent upon our environmental factors. Okay, and one of the things that we're looking at now is how all these different environmental factors. So the question is, what starts it all? Like, what is, and I think everybody is looking for that one smoking gun, but there is not just one smoking gun. There's these different variety of different potential epigenetic assaults that can happen, that can happen years before mom and dad end up having a child, okay, and that are altering their epigenetics that eventually then will alter the expression of their child's neurology, okay. Now there's certain things that are more been well documented in terms of like gestational diabetes and its role in potential changes in the immune response in the womb, and then how's that altering the immunity of a child and the expression of the brain. We're looking at different classes of medication that are being used and how that may be altering the different relationships of neuronal coding. But ultimately what we're talking about is that there's a variety of these different factors, and there's a long list of factors, and you can go to a lot of different conferences and probably learn about them and read books about it. But at the end of the day, there's a variety of these different factors that are altering the expression of the gene, and in this case, really altering the expression of the genes that code for our neural pathways. Yeah. Keep it simple.
Yeah. And you, Carol, you will see there's actually this is quite an explosion of information that's coming out on epigenetics now. And the bottom line is that we do have the ability to control what goes on. It's not written in stone, and it's about changing that environment. And that means a lot of different things. It's a whole different conversation.
Yeah, because I remember when I first started doing this work 15 years ago, I mean, some of the early work had come on epigenetics and talking about that, and talking about just how changing our diet, and we're having a diet that's low in methyl donors and our B12 folic acid and stuff like that, how it can immediately in one offspring of a mouse totally change the actual anatomical relationship of the mouse and stuff. So again, we're just looking at these different relationships that are there, but at the end of the day, we just know that there's a variety of different epigenetic influences that change the coding of the nervous system. And here's the big distinction that's so important for parents, is that it's very positive that we actually understand it's an epigenetic response versus a true genetic response. Because if it was a true genetic response and it was a hardwired genetic response, then it leads to the idea that we couldn't reverse any of the alterations that occur, where because more and more research is coming out that we're looking at all these different epigenetic determinants, that creating stimulation into the brain is actually a positive epigenetic relationship. So when we do these reflex remediation exercises, or we do a variety of brain-based stimulation, and we could always talk about all that variations and how it shapes and forms. But at the end of the day, we're stimulating the central nervous system. We're firing the nervous system at a potentiation that allows for the expression of new factors that promote coding of the brain, promote neuroplasticity. So I think that that's a thing that's really important here to understand, that we're not talking about a true genetic aspect. And I know there's been a lot of research out there about genes and finding the gene for autism and stuff like that. But even though they found certain genes, it's less than 1% of cases that they found it in, or not even 2% of cases. So it's not 98% of the rest of the cases.
Yeah.
So looking at that and saying that just because you have that gene and they may have wired that way, doesn't mean that you can't potentially change the nervous system in a more optimal way. And you know, again, for someone who's been doing this for 15 years on children and adults, and especially now where I think I'm probably one of the few people in the world that are actually spending a lot of my time working on kids that are, I call them kids, but they're not kids. They're really 17, 18, and 19-year-old and 21-year-old young adults, and that have had very dramatic developmental delays, and now seeing this change in their plasticity and functional changes, that parents are going, hey, that's something that that we've always wanted to see, and stuff like that. So they're not looking for their child to get into college, but they may be looking, okay, can my child one day hold down a job? Can my child one day be able to tell their doctor what's wrong with them? So the parents that are in that grouping of their young adult, they've changed for their hopes, and we're starting to maybe reach some of those milestones for those parents, which is exciting, because it leads to more evidence and more proof that neuroplasticity can exist, and in our brain is just not this static aspect. So for our listeners out there that know people and have children that are 17, 18 older, and you've done a lot of therapy, I want you to continue to know that we are advancing and doing more. So.
Yeah, well, and it is really important. And the way of what you're talking about is what we talk about here, My Child Will Thrive, all the time, is that every parent's and every child's journey is going to be different. And what we consider being a success is different depending on the child. So like I said, to be able to communicate is a massive milestone for any parent and child where their child hasn't been able to communicate their basic needs, let alone. But you may, and then you have the other children that have that are less affected, but still in a profound way for their life and what their aspirations and goals are with their parents. So everybody could benefit from this type of work, which is what's really exciting about it. I'm going to get to the last couple of questions here before we have to sign off.
What I was saying earlier about every patient is an N value of 1.
Yeah.
Okay? That no concussion is the same. No Parkinson's presentation is the same. Okay. No anxiety presentation is the same. And that's why I think that for our patient, or for our listeners out there, is that finding those practitioners that have a great degree of skill set and are well-rounded in these relationships to say, and again, when you get into things like mental health, there's so much that you have to account for. That is, you have to account for the developmental neurobiology, but you also got to account for their environment that they're in at that moment. Okay, do they have a really stressful job? Do they have a stressful job that no matter what you do to change their diet or do neurologically over here with rehabilitation, that they constantly keep going into that environmental stressor? Are they in a conflict relationship and stuff like that? So these are all these things that are, again, that I hope that everybody realizes that there's not this one little treatment route that we have to go down to. We have to go through this integrative model of, and I know myself and my colleagues are trying to do all that. So.
Yeah, well, and I think that was one of the things that as I experienced the IAFNR conference this year for the first time, was the very encouraging, because the encouragement for an integrative model and working with lots of different practitioners, I think it is what we are looking towards. I think the world needs more personalized medicine. And it's great to see it being encouraged on all levels. You know, the message there is that, you know, you can also work with a team of people as long as they're working together and they're working towards the same end goal. So just a couple more questions here. Polly Jane asks, have you ever seen an adult assessed 100% Neuro who has been quote unquote triggered into a full flight or fight response? And how do you get it to shut off again? I'm not quite sure. I know what that means, but you go ahead.
Again, I mean, there could have been some type of aspect that brought on the Neuro, and getting into the Neuro, we'd want to, in an adult, we'd want to assess other parts of that midbrain and look at, again, is there reasons why that we're over responding to maybe certain stimulation that constantly keeps triggering that Neuro, okay?
Mm-hmm.
And if the Neuro was once inhibited and then all of a sudden comes back, again, in that structural relationship there of that part of the brain, we want to look at, you know, what else is going on around it and then assess. And because again, you get into adults, you look at these primitive reflexes, but they're in isolation, just like the child, but in isolation of other things that are going on at that moment. Okay. Again, is it because that in that instance that the part of the structures that are around where the Neuro is they're very influenced by neuroinflammatory states. Mm-hmm. So we could be in a very high neuroinflammatory cascade state that is driving up that sympathetic dominance, and as that sympathetic dominance becomes more and more patterned, that again we're getting that potentiation of that Neuro reflex being there. Again, looking at it and saying, is it maybe because we've become more sensitive to light, or we've become more sensitive to sound, or we have an underlying vestibular problem there that's altering the aspect of that Neuro. So again, getting into that and just really digging deeper into the potential mechanism for why that Neuro might be there, and again, looking at it from a standpoint of polyvagal response aspects and stuff like that. So.
Yeah. So I'm going to just pose a couple of questions we got in ahead of time just so that they're covered as well. And if we missed your question on the live feed, we'll try and go back and answer it on Facebook itself. Joanne asked, what are your thoughts on neurofeedback? Is it effective?
Mm-hmm. Again, there's a lot of colleagues of mine. By no means I'm a specialist in neurofeedback. I think that there's a lot of different great people out there that are doing it. One of my dear colleagues, Michael Trayford over in Nashville, is probably one of the preeminent people in the country right now doing neurofeedback. I think it's something that, again, is part of the toolbox. You know, again, you know, for me, as a functional neurologist, I love to have a lot of different tools at my disposal, and I do not believe in therapies that are just monotherapies that are just one standalone. I also am biased to the fact that they're the relationship of a hemispheric aspect and looking at that is already looking at a functional imbalance, a disconnection syndrome in a child or an adult. Okay, and again, for me, I haven't studied enough of it yet, but again, is it something that I want to look at it from a hemispheric relationship as well and stuff like that? But I do know that there are a variety of people out there getting good results with that. Mm-hmm. My only concern when it comes to dealing with children is that are some of the pathways that they are trying to utilize when doing neurofeedback, are those pathways more mature? Are they been matured enough yet to have the benefit of it, or are there underdevelopment going on in subfloor mechanisms, pathways like the cerebellum and the vestibular system and the brainstem, that in order for the frontal lobe to mature, we need to address that. That would be probably my one concern in working with children. But I know that in adolescents and older, I think that there's been a lot of great work in neurofeedback. So
yeah. And Emily asks, I would be interested to learn how Erb's palsy from birth trauma plays a role in this discussion, and how best to help a child with that condition.
Well, again, with Erb's palsy, obviously we're dealing with a true structural injury to the cervical spine and the cervical nerve roots. So again, looking at that and saying that, are there reflexes there? And if they are, what can we do to try to remediate that? But again, when we get into something like that, we are still talking about a structural lesion that happened now. So without seeing the child, it would be hard for me to sit there and say what are the outcomes. But again, I think going back to and saying that it's, to me, it's this checkoff box that if I see these reflexes, I want them to be integrated, because I know if I integrate the reflexes, I'm going to have a greater degree of specialization of the central nervous system, and ultimately going to lead to higher functionality of the human mind. So anything that we can do to change that. When you get into Erb's palsy, you're talking about a variety of different factors that could change the way that limb is moving, and because of the injury mechanism.
Yeah. So to wrap up, I'm going to actually ask you Anna's question, because that's she's interested in understanding how you, if you can give her more information on how you work with people remotely.
Yeah, so the best way to do is just reach out to me through Peter Scire DC, my Facebook fan page, or you can email me by contact@scireintegrativehealth.com. That's one of the easiest ways to reach out to me. Again, the majority of my work right now is really working with young adults, working with starting 17 and up. I've been able to, over the years, because of having a clinic, now being able to develop protocols that can be done via kind of like what we're doing here, is that some patients actually fly in to see me, and we can do a very thorough comprehensive neural exam, and then maybe do some intensive therapy for several days. And some patients that we're able to do some things by guiding them through a very basic kind of neurological assessment of themselves through a variety of checklists and some basic hemispheric-based type of assessment tools to get a sense of what we may be dealing with, and then from there developing an individualized neurological rehabilitation plan. And the good news is that because of a variety of advancements in technology, some of the technology is now available for home use, that a lot of my patients will purchase and be able to do a variety of that. So that's kind of how that works. So there's two phases: either those who are local or want to fly in and do a couple days with me, and then for those who want to do it from a long distance standpoint, and then maybe sometimes choose to fly in. So.
Yeah, so we'll make sure we link to those things later in the comments or in the post here with the Facebook Live here today. But I have to thank you so much for spending almost an hour and a half here again with us today. And I know that every time we talk, I learn something new, and I'm sure that everybody here that joined us, and thanks to everybody who hung out with us for almost the entire thing. It was actually great to see so many people on live today and asking such great questions, because it really does help the conversation.
Interesting topics that they want us to explore. I know you and I have talked about maybe trying to do this on a month-to-month basis and stuff like that if our schedules permit. So definitely we're open to talking points that we want to cover. I know we have some ideas, but definitely how we want to do the best for our listeners out there. So
yeah. So absolutely, make sure you throw in the comments any additional questions that you might have right now, or ideas for future conversations that we can cover when we talk with Dr. Scire. Thank you again, and thanks to everyone that came live, and we'll do this again soon.